Welcome to the deep dive. Today, we are cracking the code on a language that radiologists and clinicians use every single day.
A language where precision is everything.
Absolutely. We're diving into the complex, crucial, and newly standardized vocabulary of the lung. The fourth edition of the Fleischner Society Glossary of Terms for Thoracic Imaging. And this isn't just, a dictionary update. It feels more like a full reset of how we talk about lung disease.
It absolutely is. And for you, the learner, our mission today is really to understand why this update was necessary and pull out the key insights. This glossary replaces the old versions from 84, 96, and 2008.
So what was the big push for the change?
Well, the drivers were simple but critical.
Yeah.
New clinical concepts have emerged. Some older terms just became obsolete. And I think most importantly, inconsistent usage of key terms was creating real ambiguity.
Right, ambiguity in diagnosis and, I assume, treatment plans. So we're talking about moving from a sort of a common sense understanding to absolute clinical standardization. That clarity is essential not just for doctors talking to each other, but for structured reports, for database searches.
Precisely. Standardization for communication and research, that's the core mandate. But before we get into the terms, there's one really, really vital caveat. The glossary emphasizes that we need to hit up front.
The distinction between what you see on the image and what's actually in the tissue.
Correct. Whenever we define terms that are labeled pathology in this glossary, so descriptions of abnormal findings, it is crucial for you to remember they are purely radiologic descriptions.
You're describing the picture.
Just the picture. They're based on density, shape, location, as seen on a CT. They do not necessarily, and in fact they often do not, faithfully reflect the exact underlying pathologic diagnosis you'd find with a tissue sample.
That distinction is huge. It means the radiologist and the pathologist are speaking two different, though related, languages.
They are. I also noticed a few structural changes in this new edition that really help with clarity.
Like how things are grouped?
Definitely. They've grouped terms under thematic headings, and there's a conscious move to reduce the number of, obscure imaging signs and eponyms. The preference is overwhelmingly for simple descriptive terminology.
I noticed that. And every term gets a label now, right? Anatomy, physiology, or pathology.
Yes, which instantly helps you organize the material in your head.
Excellent. So let's start at the foundational level. If we were building a lung from scratch, what's the first brick? The functional tissue, the parenchyma.
The parenchyma is the powerhouse. It's specifically the tissue involved in gas transfer. So you're talking about the alveoli, the alveolar ducts, and the respiratory bronchioles. That's where all the work gets done.
And if we drill down even further, we hit the acinus.
The acinus. This is the microscopic unit distal to the terminal bronchiole. It's tiny, maybe 4 to 8 millimeters in diameter, and everything inside it is involved in gas exchange.
Okay, but here's the key thing I found interesting. Normal Eschini are invisible on a scan.
They are.
So if it's invisible, what's the practical purpose of defining it for a radiologist who's looking at a CT?
Well, it gives them a frame of reference for when pathology does become visible. If you see small, ill-defined, rounded opacities, sometimes people call them airspace nodules, it tells you that some kind of pathologic material is filling up those normally invisible acini.
Ah, so you know the disease is starting at that really granular air exchange level.
Exactly. It connects the invisible dots.
Okay, let's zoom out to the key macroscopic unit we can clearly trace on a CT, the secondary pulmonary lobule.
Right. This lobule is the essential organizing unit for visualizing disease patterns. It's the smallest structural unit that's completely surrounded by a connective tissue sheath.
Giving it that sort of pyramid or polygon shape?
Exactly, that polyhedral shape, typically 5 to 25 millimeters wide. You can really just think of it as a small, discrete neighborhood within the lung.
And what are the defining parts of this neighborhood that we should be looking for?
It has 3 basic components you can see on CT. First, the core structures running down the middle. That's the bronchiole, the pulmonary arteriole, and lymphatics.
Okay.
Second is the central region where all the aschenes are located. And third, you have the outer boundary wall, the connective tissue sheath, which forms the interlobular septa.
And that's where the veins are.
Right. Those septas contain the pulmonary veins and more lymphatics.
So if the lobule is the neighborhood, all that connective tissue is like the infrastructure holding the whole city together. And we call that the interstitium. Help me visualize how we break down that support structure for description.
This is where visualization is so critical. The overall interstitium is really just one big interconnected space. But when we talk about disease, we break it into 3 compartments.
Okay, let's run through them.
First is the axial interstitium. Think of this like the main utility lines, the connective tissue that wraps around the big airways and vessels as they enter the lung, the bronchovascular bundle.
Got it. The inner cables and pipes. What's next?
Next is the interlobular or peripheral interstitium. This is the fencing, the boundary walls. It forms the septa that outline the secondary lobule.
Okay, the boundaries. And the third one?
That is the intralobular interstitium. This is the internal support structure within the lobule itself, supporting the tiny alveolar walls. When this gets thick from disease, it's what we see as those reticular lines, that netting on the CT.
That's a great analogy. The drywall inside the house. Okay, now moving on from structure, let's talk about the visual language of disease. The terms for density and pattern, starting with opacity, the non-specific catch-all.
Opacity is defined simply as any area of increased attenuation. So it just looks brighter than normal lung. And this is a perfect example of that standardization goal we talked about. This precise, neutral term officially replaces the old imprecise and now non-recommended term, infiltrate.
Getting rid of infiltrate, that clears up decades of ambiguity.
It really does.
So let's tackle the most fundamental distinction in lung density, one that really dictates treatment. Consolidation versus ground glass opacity.
The difference is all about the degree of density. With consolidation, the air in the alveoli has been completely replaced by fluid, pus, or some other material. This results in such high attenuation that it causes complete obscuration of the bronchi and vessels behind it.
So you can't see through it at all.
Exactly. But if you see a patent air-filled airway, still visible inside that dense white area, that distinct branching black structure.
That's the air bronchogram.
That's the classic air bronchogram. It tells you the airways are open, but the alveoli all around them are full of junk.
Okay, so if consolidation completely obscures the background, then ground glass opacity must be less dense.
It is. Ground glass is an area of increased attenuation, but it's more translucent. It does not completely obscure the underlying bronchial and vascular structures.
You can still kind of make out the vessels behind it.
You can. And we should stress the technical requirement here. To accurately identify true ground glass, you need thin CT sections, 1.5 millimeters or less, taken at full inspiration. Otherwise, you could easily misinterpret the finding.
That technical point is a great piece of insight. Okay, from simple density to complex patterns, let's start with one of the most visually stunning, crazy paving.
Crazy paving is a pattern defined by focal ground glass opacities that also show internal septal thickening, those intralobular lines we mentioned. It looks like cracked or irregular paving stones.
And that pattern has to point towards something specific.
It often does. While it can show up in a few conditions, when radiologists see it, they immediately think of things like pulmonary alveolar proteinosis. It's a huge diagnostic shortcut.
Then there are the more, almost poetic patterns, like tree and bud.
Tree and bud is highly evocative. It's characterized by micronodules connected to these tiny branching linear opacities, and it looks just like a budding tree. It's a telltale sign of small airways disease, often from an infection.
Okay, and we have two ring signs that can get confused, the atoll sign and the halo sign.
Right, the atoll sign, which is also called the reversed halo, is where you have a focal area of ground glass in the center, and it's surrounded by a ring of consolidation.
Like a tropical island with a lagoon.
Exactly. It was originally described in organizing pneumonia. Now, the halo sign is the opposite. It's a rim of ground glass surrounding a central nodule or mass. This often reflects hemorrhage around a lesion, or sometimes the lepidic or non-invasive growth of a tumor.
That clarity on inner versus outer ring is excellent. Let's pivot now to the language of size and scarring. We need standardized sizes, especially with lung cancer screening being so measurement dependent.
So, the size game is the foundation of nodule management protocols, like lung raids. A micronodule is now defined as less than or equal to 6 millimeters in average diameter. This is the new key threshold.
And why is that 6 millimeter threshold so critical?
Because that cutoff directly informs the decision tree for incidental findings. Nodules under 6 millimeters are often managed conservatively, maybe a single follow-up, maybe none at all. But once you cross that line, the follow-up cadence and the potential for action escalates significantly.
And a full nodule goes up to 30 millimeter?
Up to and including 30, yes. Anything bigger than that is officially a mass.
So 6 and 30, the dividing lines. And you mentioned the morphology. The internal structure matters hugely for predicting aggressiveness.
Absolutely. We classify nodules by their attenuation. Solid, pure ground glass, and part solid. And the clinical insight here is crucial. The ground glass part often corresponds to a less aggressive or lipidic growth pattern. The solid part, on the other hand, often corresponds directly to the size of the invasive growth.
So op part solid nodule is often the most worrisome because it has both.
It can be, yes.
Let's finish nodule description with the margins. Irregular, lobulation, and spiculation.
Irregular is just what it sounds like, not smooth. Lobulation is a lobule-like protrusion, but the margins are usually smooth. It just reflects different growth rates within the lesion.
And spiculation is the really scary one.
That's where you see multiple, fine, linear strands radiating outwards. It's frequently a hallmark of an aggressive process because it suggests the tumor is causing a desmoplastic reaction, a scar, or tethering in the surrounding tissue.
Moving on to long-term permanent damage. The glossary defines fibrosis.
Fibrosis is the general term for permanent repair, where normal parenchyma is replaced by dense, non-functional connective tissue. This causes volume loss and what we call architectural distortion, the visible derangement of normal anatomy.
And the most recognizable sign of established fibrosis is honeycombing.
Honeycombing is end-stage lung destruction.
Yeah.
You get these clusters of well-defined cystic air spaces, typically right under the pleura. And what's important in the new glossary is a practical adjustment. It now accepts a single layer of cysts as long as other definitive signs of fibrosis are also present.
That seems like it would speed up diagnosis.
It does, and that scarring also causes a specific change to the airways.
Traction bronchiectasis.
Or bronchiectasis for the smaller ones. It's the permanent pathological dilatation of the airways caused when surrounding fibrosis just pulls the walls open. You see it all the time in diseases like asbestosis.
Okay, let's transition to our final section, airflow dynamics and vascular anomalies, starting with air trapping.
Air trapping is the retention of air distal to a partial obstruction, especially during expiration. And the key takeaway here is methodological. You should only call air trapping on a CT performed during or at the end of expiration.
So if there's no expiratory scan, you can't reliably say it's there.
Exactly. On that scan, trapped air shows up as areas that don't increase in attenuation or decrease in volume, like the healthy lung around them does.
And the opposite of air retention is atelectasis collapse.
Right, partial or complete collapse. The glossary standardized the subtypes. Lobar is a whole lobe. Linear atelectasis is the new, better term for what we used to call plate-like collapse.
What about rounded atelectasis? That sounds like a contradiction.
It does, but it's highly diagnostic. It's a rounded mass of collapsed lung, usually right up against thickened pleura, and it's characterized by vessels and bronchi that converge toward it, creating the comet tail sign.
Seeing a collapse defined by a comet tail sign must be a very satisfying diagnostic moment.
I imagine so. It's a very specific target.
Let's talk about collapsing tubes themselves, the malatias.
We have several precise terms here. Bronchomalacia is weakness of the bronchial cartilage itself, leading to excessive collapse, like 70 to 80% on forced expiration.
But the collapse can happen without the cartilage being weak.
That's the key distinction. Excessive dynamic airway collapse is specifically when the posterior muscular wall of the trachea or bronchi invaginates too much during expiration. The cartilage is fine. The muscle is hypermobile.
And if it includes the main airways, it's tracheobronchomalacia.
Correct. And related to that, we have the saber-sheath trachea.
Which is just a shape descriptor.
Exactly. It's an abnormal shape increased front-to-back diameter, decreased side to side. It looks like a saber sheath, and it's extremely common in patients with COPD.
Finally, let's quickly cover the updated vascular terms.
Allogemia is a simple one. Focal or diffuse reduction in blood flow. When vessels get blocked, we use embolism, the lodging of obstructing material, be it a clot, fat, air, or tumor. And the damage from that blockage is an infarction, which typically looks like a wedge-shaped opacity with its base against the pleura.
We've covered a massive spectrum of incredibly dense terminology here. This deep dive really underscores how using the right word dictates the entire clinical pathway. Knowing the cutoff for a 6mm micronodule or telling the difference between consolidation and ground glass, that drives every single decision.
And that drive to eliminate ambiguity is what makes this update so powerful. For instance, the old radiographic term curly lines is now just correctly called septal thickening. It replaces an old eponym with a clear anatomical description.
So what does this all mean for you, the learner? It means that precision, down to a single descriptive term, can determine a diagnosis. And the glossary goes even further, challenging special descriptions. It notes that the prefix juxta, as in juxtaficial or juxtaplural, has been used inconsistently.
They explicitly recommend avoiding juxta, which really just means next to or near. They want you to use more stringent terms like paraphyseal, plural or plura-based. This defines exactly how a lesion is located, removing all doubt.
That push for extreme precision, replacing the general nearby with the specific in contact with, is a massive paradigm shift. And it raises a final question for you to consider. If this level of stringent redefinition is necessary for life-saving medical imaging, what other common casual terms might we use in our daily professional life that desperately need this level of standardized, unforgiving precision? Something to think about.